Hi, I'm Nitasha and I welcome you to another episode of Plain Speak. We often speak of our cities as sites of hopes, dreams and aspirations. The COVID-19, specifically for a large section of migrants, daily wage workers and informal workers, has revealed a startling reality of what the peak of the pandemic offered for them and the living realities of the urban poor in our cities. I have with me today Arima Mishra from the Azim Premji University, who's going to be talking to us about the issues in urban healthcare in India. Welcome, Arima. So, Arima, maybe we can start with why you think it is important to discuss the issue of urban healthcare.
That's a pertinent question, Nitasha, because we always talk about healthcare concerns and challenges in the rural areas, and legitimately so. We should be talking about it because those concerns remain critical. However, it's also important that we do acknowledge the growing healthcare challenges in urban areas. Let me explain this a little bit in the context that we are talking about urban healthcare. All of us, we are familiar that India is actually rapidly urbanizing and most often the process is unplanned. If we just look at the 10-year data between two censuses, 2001 and 2011, there's almost a net increase of 100 million people in urban areas. And this is going to increase many more folds in the years to come. But the question that one would ask, that usually we think urbanization is associated with better social and economic opportunities. Is that the case for everyone? Is that the case always? Because what has happened is that with increasing urbanization, the number of urban poor is also on the increase. Approximately 30% of the poor in the country live in urban areas who experience different kind of vulnerabilities, social and political, and who clearly bear a disproportionate burden of health risks and outcomes. And we just kind of witnessed what happened and what unfolded during the COVID-19 pandemic. That was a forceful reminder of the deep inequalities that our cities and towns are actually witnessing.
Arima, you mentioned about the rising urban poor population in the country and the health vulnerabilities surrounding them. So could you talk to us a little more about the provisions for healthcare that we have in the country today?
Sure. Unfortunately, we don't have a clear architecture of what constitutes an urban health system. Healthcare provision in urban areas is quite messy. And what does that messiness look like? There are a number of providers who are actually providing care, agencies who provide care. Even within the state, it's a state health department, it's the labor department, you've got industrial hospitals, you've got urban local bodies, you've got many others within the state. And there is absolutely lack of coordination and overlapping jurisdictions. Say, for example, the state health department, the urban local bodies. And not to mention, what happens is that there is an increasing, ever growing, the private sector which is actually providing care from diagnostic services to even specialty services. So what happens is that the question remains, who is accountable for providing healthcare in urban areas? Because accountability is fragmented across these different agencies.
So you've touched upon a lot of structural issues that we have today, but if you had to break it down a little bit, what are the highlights or what are the key things that you would focus on?
Yeah, so what has happened is that because of this kind of provision of healthcare, and how does it impact the urban poor, for example? And I'll highlight two aspects of it. If we just look at the data in terms of the government data, recent data, the number of primary health centers, and as we know, the primary health centers are the first institutional contact for many, and it's all the more important for the urban poor. We don't have even approximately 40% shortage of primary health centers in urban areas, and that really directly impacts access to basic care. What happens is that in this context is that studies show that many poor patients they forgo treatment, they don't seek care treatment. For example, in a recent kind of a study among the urban homeless in one of the cities in eastern India shows that more than 80% of the sample that they had interviewed, even if they had illnesses, they never sought treatment. And what also happens is that because I don't have the very clear referral structure, I might have been diagnosed with, say, for example, diabetes in a camp, right? But so screening of a particular health condition in camp, I would be going to another place for diagnosis, another place for buying medicines, to another place for follow-up. Care is kind of fragmented and uncertain across these different sites, which becomes completely unsustainable for the poor and the vulnerable groups. More worrying and more concerning is that people are forced to seek care in the private sector, and the difference in terms of cost between the public and private is actually 8 times in terms of cost.
So Arima, you spoke about the 8 to 10 fold difference in cost is quite a revealing statistic. Could you elaborate a little bit?
Yes, absolutely, that's true. And what happens is that it really pushes the already poor into further impoverished conditions, and obviously they kind of don't continue with care, and particularly with chronic non-communicable diseases, continuity of care is critical, and hence they are much more vulnerable to adverse health outcomes, including mortality.
So Arima, what would you suggest are the key steps that we can take to address equity in healthcare?
Yeah, it's important. So as we have been discussing, the problem is vast and quite complex in that sense. There are many steps that need to be taken, but I would like to highlight some of them. Immediately I think it's very important that we need to fulfill the National Health Mission norms of human resources, including particularly at the primary health center level, and strengthen the primary health sector infrastructure. What would at least it will allow is to provide integrated care from screening, diagnostics to follow-up to continuing treatment in one stop, so that it would reduce unnecessary referrals, it would reduce out-of-pocket expenditure. It's also important that we need to prioritize and address and strengthen primary health care in urban areas, because we always talk about primary health care in rural areas, right? But we have never spoken about primary health care in urban areas. What it means is that we need to focus not only on the curative care, but we also need to focus on the preventive care, health promotion, preventive and promotive kind of care, which really focuses on community participation, intersectoral actions, because health is really deeply connected to nutrition, sanitation, access to safe drinking water. So this must be part of how we actually approach healthcare. It's also important, another component, particularly at the community level, that one could do, and evidence is there that it works, is that we need to kind of strengthen the capacity of the frontline workers, the ASA workers, the Anganwadi workers, the ANMs. And what would that capacity building basically entail, in the sense, because it would allow them and empower them to proactively address the needs of these vulnerable groups. And the capacity building should be sensitive to this different, the distinct nature of vulnerabilities, and in that sense the different determinants of these health vulnerabilities, to identify and address those, right? And also what would it require is that their capacity building should also include the demands, the changing demands of the disease burden, because now it's a non-communicable diseases is an increase, and non-communicable diseases requires a slightly different approach than we are talking about maternal health care and other kinds of communicable diseases, and that really needs to be part of their capacity building.
You mentioned quite a lot around service delivery and how we can bring communities and stakeholders together. Could you also talk a little bit about policy?
Yeah, true. We need to address issues at the policy level as well, and there is no shortcut, right? If we are talking about health for all in all, the entire country, including urban areas, we really need to strengthen the public health system. But also it's important that we need to move towards a universal health system kind of imagination, which really brings together the different actors, both within the public and private, to address this kind of fragmentation of urban health system, right? It is also allow us to leverage, health resources, which are there across different kind of, actors and agencies. And Nitasha, we have actually brought about a report on healthcare equity in urban India, where we have detailed what the urban health system architecture looks like, what is the nature of vulnerability of different kinds of groups, and what are the different steps that we can actually take at the community level, short term, medium term, long term. And I hope this is going to be kind of useful for everyone, because as you would kind of imagine through our discussion, Nitasha, that urban health is at crossroads. With the increasing pace of urbanization, the number of urban poor is going to increase, and this whole health inequalities are going to be kind of more intense and wide. And it's important that we acknowledge and we address it on a priority basis.
Right. I'm quite eager to read the report, Arima. It's been such an engaging and insightful conversation. Pleasure speaking with you. Thank you so much for joining us.
My pleasure, Nitasha. And the report is available on our website.
Thank you. After a very interesting conversation with Arima, we have Adithya Pradyumna from the university to continue talking about issues in urban healthcare. Welcome, Adithya.
Thank you, Nitasha.
So as Arima mentioned, the urban poor face a disproportionate health risk in the country today compared to other communities. So could you explain a little bit about the specific challenges?
In order to understand about the health challenges of the urban poor, it would be good to first address the question, who are the urban poor? They are not a homogeneous category. Rather, they are a very heterogeneous group, and each subgroup is characterized by their own distinct vulnerabilities. We could take one example to help us understand about this heterogeneity. Majority of the urban poor live in slums, but there are many who are also homeless, who live on pavements and in other public spaces. And if you look at slums, all slums are also not the same. There are some that are officially recognized, but there are many others that remain as informal settlements. And informal settlements are often deprived of basic services from the government because they are often invisible to the state. But these services are actually very important for protecting and maintaining health.
Could you further elaborate on the factors contributing to the health risks faced by these vulnerable groups?
Sure. The health vulnerability of the urban poor is quite complex, and it emanates from a range of overlapping and intersecting factors. So, for example, an important one is poor living conditions, which includes aspects such as inadequate access to potable water and inadequate access to improved sanitation. Then there is also the precarious and hazardous occupations that those living in urban poor households are often involved with. We also see that the urban poor are often socially excluded from the various services and facilities that urban areas have to offer. And finally, there are also factors such as urban poor households, the vulnerable households, are constantly on the move. They move from one place to another, often in search for work and a better life. But this constant movement also creates challenges to keep them consistently linked with services that are offered by the government or by civil society organizations. And all of this adds to the health vulnerability.
Right. So, Aditya, can we bring this to life with an example? So, maybe you could talk to us about a specific vulnerable group and the kind of risks they face on a daily basis.
Yes. One group that are often identified as especially vulnerable in the urban context is the recently migrated young married women who come to live in informal settlements. These women have no experience of living in the city. They are unfamiliar with their neighborhood, and they have no social linkages to speak of. They also don't know about where and how to access the local governmental health services. In addition, their spouses are away for several hours a day on their work, and they also face other challenges such as domestic violence quite often. So you see, this shows us about how each group has their own very specific, distinct vulnerabilities.
It is really unfortunate that our cities that are full of wealth and infrastructure are struggling to provide for the urban poor, which forms a very big component of our cities. Do you think that vulnerability stemming from living and working conditions contributes to disparity and health risks?
Yes, Nitasha, they definitely do. We can look at an earlier study from a few years ago, which talked about life expectancy. So the life expectancy was 9 years lower among men and 6 years lower among women from the poorest sections of the population as compared to the richest sections of the population in urban areas. And we can also look at large national surveys which are conducted periodically in India, and they give us a good idea about disparities that exist. Of course, it's important to keep in mind that these surveys do not adequately represent the most marginalized sections, such as the homeless population are not adequately represented, but still they give us an idea about the disparities that exist. So the national survey from 2015, for example, showed us that the urban poor are facing a disproportionately high burden of health problems in urban areas. We can take an example of non-communicable disease to understand this further. See, often there is this perception that non-communicable diseases like diabetes are mainly the problem of the wealthy, of the rich, especially in the Indian context. But the data revealed that the prevalence of diabetes and hypertension among men aged 15 to 49 years of age was actually very comparable between those who are in the poorest sections of the population and the richest section of the population. So now this is a problem because non-communicable diseases are for life. They need to be managed for several years. They're expensive to manage, and they also lead to more serious consequences such as stroke, heart disease, and kidney disorders. And each of these can add a major burden to the household. We can also maybe look at another vulnerable population to understand about this disparity. So the children, for example, and the prevalence of child underweight, we see that it is much higher amongst the poorest section of the population as compared to the richest. It was at the order of 50% almost amongst the poorest section as compared to around 20% amongst the richest section of the population. And this again shows us the disparity and the burden that the children have to carry throughout their lives.
So we've all heard about malnutrition in children, and that's quite commonly understood, quite prevalent. But it is very surprising to note such a high prevalence of non-communicable diseases. Is it the same for communicable diseases as well, like tuberculosis?
Yes, it's definitely the same for communicable diseases as well. We can first look at improved sanitation as an indicator. So improved sanitation is important, as you know, because it is an important determinant of communicable diseases. So the access to improved sanitation was just at about 21% amongst the poorest section of the population in 2015, as compared to 100% of the population amongst the richest section. So this may have improved over the last few years, but we still see that there was a huge disparity that existed. And now we can also look at the example of tuberculosis, which you gave, which is an important communicable disease in the Indian context. So for households that were reporting at least one member who currently had tuberculosis, we see that the prevalence in urban areas was actually lower than rural areas. But when we disaggregated the data, we saw that the prevalence of tuberculosis was actually the highest amongst the urban poor, even higher than the rural poor. And this shows how the averages sometimes hide the great disparities that exist in the health situation in urban areas.
Right. And we've seen this most recently in the pandemic. So your views on how it sort of played out over the last 2 years?
Oh yes, absolutely, Nitasha. I think COVID is a relatable and a useful recent example to help us understand about health vulnerabilities and disparities that exist in urban India. So we saw that people who live in urban poor settlements, they faced much greater challenges with physical distancing, with accessing healthcare, whether for COVID or for non-COVID related challenges such as maternal healthcare, for example. And these sorts of challenges, we saw that they just kept adding up. In fact, the earlier part of the pandemic, they also faced challenges to access food and water. In addition to this, a large number of people from the urban poor settlements lost their livelihoods during the initial part of the pandemic. And many of them were also working in frontline work, such as in waste management, for example. And we all also remember, seeing the challenges and the humiliation that was faced by migrant workers, who often live in informal settlements, but they were trying to find their way back home, and they had to face several challenges. And all of these factors for sure have added to a great degree to the health vulnerability of the urban poor.
Right. So hopefully healthcare, especially in the urban poor context, gets the attention it deserves. Thank you so much for speaking with us. It's been such a pleasure.
Thank you.
With that, we come to the end of this episode. I hope, like me, you've also understood a little more about the complexities and nuances of urban healthcare. Until next time, see you then.